psychiatry, pathology, sleep. All right, so there's a couple of things that you need to know for sleep disorders when involving psychiatry. The first one going to be sleep terror disorder. We already discussed this when we were discussing neurology and the sleep cycle, but it's very key to understanding this. Whenever someone has sleep terror disorder, it's going to be associated with a child that is in N3. Okay, so child, it's occurring usually in the N3 non-REM 3 stage. Okay, and the patient's usually going to be screaming in inconsolable terror. They'll say inconsolable terror. So they're not able to be consoled. And they will have they won't be fully awake. They'll have no full awakening. And so then that leads to them not remembering the episode later on. So that's our night terror disorder. And they love to contrast that with nightmares. Nightmares in children, the child's going to remember the night terror or the nightmare, and it's usually going to be in REM sleep. Okay, so remember that contrast between nightmares and night terrors. Night terrors is in N3, non-REM 3. It's going to be associated with not fully awakening up, and they're inconsolable, and then they will not remember it in the morning, whereas nightmares is usually in REM sleep. They will remember it, and that's pretty much kind of your main takeaway. Next is enuresis. Nighttime enuresis is just like essentially the patient's peeing the bed. Okay, so it's just urinary incontinence during nighttime. Greater than 2 times per week for greater than 3 months is going to be your definition of enuresis, nighttime nocturia. But it's going to occur in patients greater than 5 years old. If it occurs in less than 5 years old, then it's physiologic. It's fine. But if it's after 5 years old and they're continuously occurring, then you think that it's some type of pathological cause. Okay, so you're just going to have first-line treatment is just behavioral modification. Okay, so making sure they go to the restroom before they go to bed and stuff like that. All right. Next is narcolepsy. Narcolepsy is excessive daytime sleepiness. Okay, so I'm sure you've seen narcolepsy multiple times just through social media, people experiencing it where they just fall asleep while doing something. Okay, but it's not really like that. The way that it's going to present in the question stem is going to be excessive daytime sleepiness with recurrent episodes of rapid onset sleepiness, usually due to like an external excessive factor. Okay, so what does that mean? Like if someone laughs too hard, then they'll fall asleep. Or if someone becomes so scared, they'll fall asleep. So it's usually triggered by something, okay? And it has to occur for greater than 3 times per week for 3 months. Once again, that's not too high yield because narcolepsy is very easy to point out. But what they want you to know is that you'll see excessive daytime sleepiness despite awakening feeling rested, okay? Because there's a difference here. When we have obstructive sleep apnea, patients are going to be waking up feeling not rested well, and then they'll have excessive daytime sleepiness. Here we have excessive daytime sleepiness, but they wake up feeling very well rested in narcolepsy. So that's a key feature. Another key feature is that they have cataplexy. So cataplexy is just essentially the loss of all motor function. Okay, so essentially they become somewhat paraplegic in for a quick second. So they lose all motor function, and that's what essentially causes them to just sleep and just stop suddenly. So it's loss of all muscle tone. Due to a strong emotional stimulus, like laughter, for example. Remember when I discussed laughter and fear? So it's going to be, the cataplexy is highly associated with narcolepsy. Now, another thing associated with it is going to be sleep paralysis. So it's going to be associated with a lot of REM phenomena, like moving around in your sleep, fighting off people. You're actually moving in your sleep. And then you also have prolonged paralysis in REM sleep. And then what they want you to know is how kind of the pathophysiology occurs for narcolepsy. It's due to decreased orexin. Another word for orexin is hypocretin. You're going to have to know both of those. That is the highest yield thing for narcolepsy. I think I pretty much got asked every narcolepsy question is the pathophysiology behind it. It's due to decreased orexin, or another name for orexin is a hypocretin. So decrease in hypocretin or decrease in orexin will give you the right answer. Okay? Very important. Highly associated with narcolepsy in the questions. Okay? Now, how do you treat? Good sleep hygiene is kind of the first line treatment, right? You don't want to give someone meds, but if you can't, then you're gonna give them daytime stimulants. So you want to keep them awake while they're awake. You want to keep them awake during the daytime. Keep them awake. Okay, so then that way maybe they can sleep better at night, and then that way they don't have to sleep randomly throughout the day. Okay, and so that's gonna be amphetamines and modafinil. All right. Once again, narcolepsy main features. Excessive daytime sleepiness despite awakening feeling well rested. They have recurrent episodes of rapid onset, overwhelming sleepiness. Okay. You have associated cataplexy and REM phenomena. It's due to decreased orexin and hypocretin. And another thing that we already discussed previously is that it could be associated with some type of hallucinations like hypnagogic or hypnopompic, which is hypnagogic going to sleep hallucinations and hypnopompic just before waking up with hallucinations. All right. And you're going to treat them by keeping them awake during the day via daytime stimulants like amphetamines and modafinil. All right. So that's kind of our sleep disorders when it comes to psychiatry. If you have any questions, once again, please reach out.